Okay. Mhm. 2 years, yes, sir. It's only a couple lectures. All right, perfect. Well, good morning. My name is Caleb Griggs. I'm a third-year medical student at VCOM. I think Dr. Scorin mentioned that the earlier we finish these presentations, the earlier we can maybe get to breakfast. I know at 6 o'clock, that is probably what most people are thinking about. I could definitely use a cup of coffee. So, for my research paper, we did on the topic of statewide access to ophthalmologic care in South Carolina, and it was a secret shopper evaluation of appointment availability. I did want to take a moment to mention and acknowledge Dr. Alejandro Esplot, who's the primary author on this paper, and he's a ophthalmologist in the Prisma USC department in Columbia, South Carolina. This project was kind of near and dear to me personally as a South Carolina native resident. I was born and raised there, and I hope to practice there one day. And so, yeah, just very interested to see what our access currently looked like. For some background for this research paper, as we all know, delays in eye care can lead to irreversible vision loss. In this study's case, we looked at how quickly patients get intravitreal injections and YAG iridotomies more urgently. And then national access models currently depend on provider counts, Medicare billing data, and then self-reported survey estimates, usually from office managers or employees of those offices. So that's what our current models support, but these may actually reflect real-world scheduling. So knowing that, we noticed a study gap. There's limited data on real appointment availability, and we needed an evaluation across procedures, regions, and call types. And so that's what we did. But why choose South Carolina? Other than the fact that the majority of the physicians and the medical students involved in this study are from South Carolina and currently attend VCOM Carolinas, we also partnered with South Carolina Society of Ophthalmology, whom had the contact list for all these offices that we were able to gain from them and then contact those offices. So that made it convenient for the study itself. On top of that, South Carolina is a model state in the country for kind of this ideal setting to assess ophthalmic access because it has urban, suburban, and rural areas, and then diverse health systems with diverse health access. Some patients in certain regions have to travel really far to get ophthalmologic care, and some are within 5 minutes of an office. So it can be a model state for any future studies if we wanted to do this anywhere else. So for the objectives of our study, we wanted to measure the next available appointments for several procedure types, and then compare what a new patient would be calling this office versus if a referring provider was calling these offices, and then assess the provider-provider communication. If a physician called and wanted to speak to another provider, could they make that happen and how quickly? So for our study design, we decided to set this up again as a cross-sectional secret shopper study. It was done from January to June 2025, took a total of 6 months. And as I said, we had 2 call types. So new patient versus saying that we were a referring provider and needed to see how early we could get our patient in because we thought something was concerning. The 5 procedures we evaluated were a YAG laser iridotomy, an intravitreal injection, lid lesion evaluation, YAG laser capsulotomy, and selective laser trabeculoplasty, or SLT. The first 2 procedures, the YAG laser iridotomy and the intravitreal injection, were considered more urgent or emergent procedures when we were asking, and then lid lesion evaluations, YAG laser capsulotomies, and SLTs were considered more routine care. So 156 practices were identified, 111 were included, 2 call types, the new versus referring provider, those 5 procedures, and then we got our outcomes. So our outcomes were mean wait time in days by procedure and call type, regional variation through the state of South Carolina, and then provider responsiveness. The mean reported appointment availability across the entire state followed a fairly strict and consistent pattern, with a YAG capsulotomy having a wait time of about 19 days from call time, SLT having 19, and then 18 for a referring provider. Lid lesion evals were taken about 10 days for a general patient calling in and just saying, I have a bump on my lid, how soon can I get in, versus a referring provider saying they see something concerning, that being 1 day versus 10 days. Perhaps they would treat that a little more emergently if a provider was saying they see something concerning. And then YAG iridotomies and intravitreal injections, the two more urgent procedures, had a same day or 1 day wait time. And so, and then those showed no difference with general versus referring. If the patient said that this is urgent or my eye was hurting, the offices would usually say we would work this patient's in. The regional variation was fairly consistent across the board. There are a couple outliers. The PD region, which is the purple region in the upper northeast region of South Carolina, saw about a week less or a few days less in the urgent procedures case than the rest of the state, which is a little surprising. We figured the upstate region would have a greater access to care, quicker access to care. But other than that, the rest of the regions follow a pretty standard pattern. As far as provider communication went, most practices did offer same-day callback. So they said that they would leave a note for their doctors, and then they would usually get back to them within 30 minutes or an hour. And then many allowed direct physician communication, where they would say, we'll just normally go get the doctor on the phone right now, particularly if you're saying you have another provider and need to speak. And so providers were able to get right on the phone most of the time. So interpretation of this data, it seems that our system in South Carolina is highly responsive to urgent needs. Routine care represents the bottleneck at about 3 weeks, but access is better than provider counts, Medicare billing, and self-reported surveys suggest. Some limitations of this study: we do acknowledge that scheduling does not equal treatment. Just because an office says that we can fit somebody in 2 to 3 days and they get an appointment does not mean that they are actually going to come in and get the laser treatment done. It does not consider clinical triage, so these call center individuals or physicians or scribes, varying individuals that would answer our calls, did not necessarily go through the triage questions and kind of develop a sense of urgency for that patient calling in. It does also not include insurance-related barriers, patient travel burden, or actual time to treatment. So just because an office says that they can get a patient in a week, doesn't mean that they'll actually be able to get there. Their insurance will actually pay for the procedure, or that they can get over a travel burden, which seems to be a large barrier to access, especially in some of the more impoverished areas in South Carolina. Some practices were excluded, particularly ones that when we called said that they refer out for all of these procedures. So in conclusion, and some take-home points, expedited care in South Carolina is widely available for truly emergent procedures, usually about 1 to 2 days. Routine care is the bottleneck, scheduled within 3 weeks. And then it does seem that a secret shopper method does capture real-world access versus our other models that I've mentioned previously. Thank you. And are there any questions?
Good talk, first of all.
Thank you.
I think these things come out, especially when you start talking about scope of practice issues, and we deal with optometrists as well, but optometrists use this kind of information to say lack of access to care, so we should be able to do iridotomies or SLTs or that kind of thing in certain states. And so, I guess, what did you think about that, or what do you think in South Carolina? Is this like how it would affect like scope of practice and those kind of issues?
I think one of the kind of sparking ideas for doing this study, and some of the ophthalmologists that kind of were over this study idea, was to answer the question of scope of practice and say, do we truly have an access barrier in South Carolina to justify bringing forward legislation that would change that and give more scope? And so this is just kind of general data out there in case that question ever does come up, and it has in South Carolina a couple times in the last few years. So this will be both for that. Sure. South Carolina does not currently allow optometrists or have any law that allows optometrists for a scope of laser procedures. They do not, no, sir. And the argument, I think, in the past few years has been that patients are waiting too long for these urgent procedures, and it's dangerous, and so they do need that increased scope. But from across the board, we were able to see same day to maybe 1 day for get these procedures done. Yes, sir.
While you were doing the study, did you look at time, how many rings it took to get a call at certain offices or things like that? Because that's the biggest complaint you get from patients as well, is that, it took 10 times to get a call, or I couldn't get. What did you guys experience on that?
Out of the 156 offices, the 111 we included, I would say 95% of those offices responded in the first ring. So, I mean, it was not difficult to get a hold of those. There were probably 20 to 30 offices we had to leave voicemails for 1 to 2 times, and then many of those just ended up not getting back to us in time. We gave it 6 months total, but they just never got back to us. So most of the time they were very responsive.
So you said an interesting thing. You said that some of the offices you contacted said they don't do it in these procedures.
Yes, sir.
Were they because they were retina specialists or offices, or it befuddles me to consider anybody here, unless you're super specialized, you just do left eye cataracts and nothing else. You would not do
Sure.
none of those procedures, but if not all of them, that's bread and butter procedures for most general ophthalmologists. So
Right.
can you expound on that? Because I don't even understand.
There were, I think, 3 practices out of the 156 we called that specifically said we refer out for all of our procedure types. We did not take the time to delve into why that was. We did find that interesting, and we noted that in the data. But that was the case. We don't know why they preferred out.
Retina specialties practices or something in general.
Right. They were usually ophthalmologists and optometrists, kind of mixed practices. Now, they may have had, the ophthalmologist might have been out on leave, anything like that. We did not delve into the reasoning behind that, but they said at this moment we are currently referring out for those procedures. So it's, yeah.
And the only other thing is, the college itself is which one, in your geographic map, which section does it fit in? Midlands or?
VCOM itself? Or?
VCOM.
Yes, sir. Upstate region. Yes, sir.
Upstate.
Yes, sir. Mhm. All right. Any other questions?
Okay, well, thank you very much.
Yes, sir. Absolutely.
A lot of good questions. That's wonderful. All right. Adaraj. You ready? Hopefully. So he won second place. And he informed me, I guess I didn't know which school that he was going to, that I also teach at his school.
Dr. Scorn does teach at Nova. All right. Good morning, everybody. Thank you all for coming today. I appreciate it. My name is Adiraj Sibia. I'm a third-year medical student at Nova Southeastern University. Today we're going to be talking about diabetic retinopathy management and the shift that we have seen from laser to pharmacotherapy. And this is a national Medicare analysis. I would like to thank Dr. Shalom, CareSet, Dr. Patel, Dr. Hallman, and Dr. Gupta for allowing me to help work on this project. There are no relevant financial relationships to disclose. So let's start out with some background in pathophysiology. So diabetic retinopathy remains as one of the leading causes for vision loss in working age and older adults. There's 2 main types of diabetic retinopathy. There's diabetic macular edema, known as DME, and this causes central macular swelling and decreased vision, historically managed with focal or grid laser, and now commonly with anti-VEGF therapy. The second part of diabetic retinopathy is proliferative diabetic retinopathy, also called PDR. This causes ischemia-driven neovascularization and may lead to vitreous hemorrhage or tractional retinal detachment. Traditionally, treatment centered on panretinal photocoagulation, or PRP, but now again we're also seeing a shift to anti-VEGF. And so landmark trials like the Protocol S and Panorama support that anti-VEGF for diabetic retinopathy regression and control are the way to go. However, these frequent injections and repeated follow-up introduce real-world adherence challenges. So that brings us to our study objectives. Why are we doing this? It's threefold. 1, to characterize national trends in diabetic retinopathy treatment in Medicare. So we looked at data from the years 2017 to 2024, and to quantify care gaps, including undertreatment, declining screening, and follow-up burden, and to evaluate regional variation in anti-VEGF therapies and laser therapies. So that brings us to our methods and data source. So our study design is a retrospective national claims analysis from 2017 to 2024. Our data is 100% Medicare fee-for-service claims. Our population is people with diabetes and confirmed DR. Our index treatment is first recorded diabetes retinopathy treatment with anti-VEGF or laser within the study window. And our exclusions are Medicare Advantage enrollment, non-continuous FFS, and no diabetes, and no non-diabetic retinopathy retinal diseases, including AMD and RVO. These were the CPT codes that we'd used. So what was our cohort? We had over 388,000 people, mean age of just under 68 years old, a 51% male sex distribution, 67% of our patients were white, a largest share geographically being in the South at 39.5%, and a clinical mix predominantly of PDR at 91.5% and 10.8% of DME. So what were our results? We started out with, as you could see here on the left side, the top left is 2017 data, and then kind of going down to 2024 data. We see the decrease from 58,000 to 51,000, and then the increase in anti-VEGF therapy from 2017 for PDR being at 66.8% to a jump to 85.3% within that 7-year time span. And these are some of the main things, and now I'm going to talk about some of the more detailed and important information to take from that table. So starting out with anti-VEGF has become the dominant therapy for both PDR and DME. So PDR anti-VEGF therapy increased from 66.8% in 2017 to now 85.3% in 2024. PRP treatment has decreased during that time from 53.1% to 30.4%. For DME, anti-VEGF rose from 79% to 93%, while PRP fell from 35% to 14%. We also saw a volume drift, which is like a decrease in the number of people treated for proliferative diabetic retinopathy. That fell from 13%. That fell about 13%, and the people with DME, that number fell from around 11%. The other major thing that we saw while collecting our data is the annual diabetic eye exam. That rate had dropped from 72.9% to 58%. So after our initial eval, the next thing to look at are follow-ups. So we looked at the follow-ups from a 6-month period and a 12-month period. Follow-up remained relatively high, which is good, but declined over time. PDR adherence exceeded DME at every interval. Early adherence was strongest at 6 months, with PDR being at 86.4% and DME being at 81.7%, and a 12-month follow-up being for PDR at 78.3% and DME being at 75.4%. I think the key thing to take away here is injection-based therapy may make longitudinal adherence a key determinant of outcomes. So the next thing we looked at was regional variance. Anti-VEGF was highest in the Northeast at 87.7% and in the South at 86.6%. Laser therapy remained relatively higher in the Midwest and the West. I think the key thing to look at is the differences may suggest variation in access, practice infrastructure, referral patterns, or local preferences. In other words, where a patient receives care may still influence how they're treated. So discussion. This is probably the most important stuff that we're going to talk about here today. What's our major finding? From the years of 2017 to 2024, national practice patterns have shifted from laser toward anti-VEGF therapy. And why is this happening? So one, clinically, you see improved control of edema and regression of neovascularization, and this is strongly supported in the Panorama and Protocol S trials. And so let's kind of look at the strengths of both of these different treatments. So the strengths of anti-VEGF are strong visual outcomes, rapid reduction of edema, and regression in neovascularization. The strengths of laser, however, are durable treatment effect and lower long-term visit burdens. The main question here is the most effective treatment always the most sustainable real-world application in our populations? Okay, discussion. This is kind of looking at the future and care gaps. So the first question is, why might treated numbers fall despite rising diabetes prevalence? And so some of the things that we talked about and are thinking are declining annual diabetic screening rates. This study took place during the COVID pandemic, so 2017 to 2024. Has COVID kind of had a change in our results? A loss of follow-up to transportation burden for our patients. And then another thing to also potentially look at is a shift from Medicare fee-for-service to Medicare Advantage, which we were not able to capture in this study. So, future directions, where can we go from here? Longer acting anti-VEGF agents, that would be kind of nice. Treatment and extended protocols, expanded diabetic screening pathways, and right now as a third-year medical student, I'm on my rural rotation and have a lot of experience with telehealth. I asked all the other ophthalmologists in the room here, like, would telehealth or for ophthalmology be possible for some of our patients that are not able to get care and have follow-ups? In conclusion, our key main takeaways are diabetic retinopathy treatment in Medicare shifted markedly from laser toward anti-VEGF therapy from 2017 to 2024. Despite therapeutic advances, screening rates declined and treatment gaps persisted. Long-term success depends not only on efficacy, but also on access, adherence, and sustainable care delivery. Future innovation should reduce treatment burden while preserving outcomes. I think the main thing to end off here with is progress in therapy must be matched with progress in delivery. These are my references, and thank you all for your time.
Any questions? So I found out this is being recorded, so you'll have to talk into the microphone so the questions could be heard for the recording.
Hey, that was a great presentation. I was just wondering, did you find like a hybrid model in any practices? They were using both anti-VEGF and laser?
Yeah, that's actually a really good question, and that's kind of where some of the practices are taking it. I think that might be the answer long term. I honestly am not sure, but it's the hybrid model allows for the longer term follow-ups to happen with the laser, and then the anti-VEGF for that better control of the edema.
Yeah, I think for the ophthalmologist here, the answer is we use the hybrid model, as you call it. It's not really a hybrid model, is because it depends. If the person's presenting with a lot of proliferative changes, you wouldn't do anti-VEGF right away. You have to try to stabilize things with laser, and then you go and add anti-VEGF. So it's actually a clinical, it's not a hybrid model, it's more like a clinical approach to it. Any other questions? No?
That was a great talk. Back in the days when we started doing focal laser, we made a big deal about what we call CSME, which was clinically significant macular edema. So in your study, it looked just like you used the term diabetic macular edema. So are we just, I mean, sometimes we didn't treat if there's macular edema that's outside of the fovea, we just sort of watched it, or there's some patients that see, 20/20, 20/25, and they've got diabetic macular edema, but it's minimal. So deciding to treat that is sometimes physician dependent, and obviously you don't really treat macular edema that involves a fovea with a laser. It's got to be extrafoveal. So, I mean, I think that there's some ways to really break down diabetic macular edema that maybe weren't completely covered in the study that might affect the treatment. So this is a little bit minutia, but I'm just curious to know if you looked into any of that, or when you researched, did you look at the difference between sort of clinically significant macular edema and just DME? Yeah,
no, that's a great question. The answer is we didn't. We looked at both PDR and DME, and 90% of our patients were PDR, so nowhere near as many patients were DME, so that's kind of why we didn't. This is kind of more of like a bigger umbrella kind of project, and didn't get the opportunity to look into that. However, that is definitely something in the future that we can look at, and I would be interested in looking into that.
Great. You said that Medicare you were able to get, but the other one, the Advantage, you weren't. Why couldn't you get access to both?
The other one is, hold on, let's see if we can go back here. Yeah, so Medicare Advantage plan was not able to be captured because that is when we had other private insurance companies, and we just didn't have access to that. We only had access to CareSet.
Okay, that makes sense.
Yes.
Okay, good. Any other questions? No? Okay, thank you very much.
Thank you. I appreciate you all.
Okay. And the number 1 paper, Tristan Cook. Are you a resident? No. Oh, I was going to say, residents dress casual. But.
Yeah, this is my first time at one of these, so apologize for underdressing. Yeah, it's fun to be with you guys this morning. Just as a quick introduction, my name's Tristan Crook. I'm a second-year medical student at Nordicom in Provo, Utah. We had a great team working on this project. What I want to walk you through today is we did a comparative study and a pretty comprehensive literature review that was looking at the visual outcomes between 2 different type of lenses. We looked at the Technis Eyhance. This is a Johnson & Johnson IOL, and then also just a standard monofocal. And we wanted to kind of look at the 2, and I'll get into why we did that. We had a great team working on this project. There's somebody here, Alex Neiman, he was part of the project. But we really did have a pretty good group of students, residents, and refractive surgeons to help work on this. This paper was actually published earlier this year in Medical Education, Hypothesis, Discovery, and Innovation in Ophthalmology. And I left the DOI up there if anybody's interested in looking it up. But I'd also be happy to share the PDF at the end of this. Okay. Does this just go forward? So this is a little bit unconventional. I know. A lot of us are kind of here, especially students, just trying to meet each other. So I thought it'd be fun to throw a little introduction slide in here. I grew up here in Arizona, so I'm not too far from home. After graduating high school, I did move up to Utah. I went to BYU and then decided to stick around in Utah County to get a business degree and then also to, of course, to attend NORDA. I have a wife and a daughter and a couple of pets that kind of throw the chaos into the home. Big sports fan, love playing board games, and I love music. So the meat and potatoes of the presentation here is what's the point? So before I dive into our methods and our results and some of the nitty-gritty, just a big overview. Back in 2003, Johnson & Johnson, their vision department, they released a standard monofocal intraocular lens. Pretty... Sorry. Yeah, pretty standard intraocular lens. And then just a couple of years ago in 2020, they released a new lens called the Technis Eyhance intraocular lens, and it was essentially, as far as FDA regulation, it was just an upgrade on their old PMA, their old FDA pre-market approval. And so what that meant is instead of having to create or to release new clinical data that presented their findings with this new lens, the Technis Eyhance, they were able to produce and get approval from the FDA based off of their old PMA from this 2003 lens. The problem with that, though, is it didn't match their marketing. In all of their marketing literature, they were saying that this new Technis Eyhance lens kind of matches more of an extended depth of focus type of lens instead of your standard monofocal. They were promising patients that they would be able to have preserved distance visual acuity, but also an addition of intermediate distance or intermediate visual acuity, which is about arm's length or the distance of a computer. And so this kind of creates a problem, a bit of an evidence gap, where we have the marketing, we have what patients are seeing, we have what our physicians are seeing in the clinic about this lens, but no real data to support it. And so that's really where this project came into place, was to take a look at this lens, to compare it to their old 2003 standard monofocal lens, and determine if there really was an improvement in intermediate or near vision. So also just a little bit of context here. The IOL spectrum, kind of three major types of intraocular lenses that I want to focus on throughout this presentation. The first one is just your standard monofocal lens. The standard monofocal lens, that was kind of our comparator, has one focal point, excellent distance vision, but patients do need readers for this. But they are pretty well known for having very limited amounts of dysphotopsia, and that's referring essentially to glare and to halos, starbursts. And then in the middle here we have the extended depth of focus lens, which is kind of the category that our eye-enhanced lens falls into. That is, an elongated range. It's not quite the crisp vision that you're going to get compared to multifocal lenses at different distances, but it also has fewer cases of photic phenomena. And we're going to get a little bit more into that. And then, of course, we have multifocal lenses, which weren't really a huge part of this study, but are relevant for a later slide. And that's a lens that creates different focal points, allowing patients to see pretty crisp at the distance, intermediate, and near vision. But with that, they also kind of come with higher risk of the photic phenomena. So the optical design of the Technis Eye-Enhance, the starting point is pretty important. They built off of that old standard monofocal, but they did make some adjustments, especially on the anterior surface. The only thing that was really redesigned was they made some changes to the anterior surface where it created a continuous gradual change from the outside to the inside of the lens, with a gradual change in power. So instead of diffractive rings that you see in a multifocal lens, you get essentially kind of more of a funnel going into the back of the eye that allows patients to get kind of a full range or an extended range of vision. The two models that are commercially available right now for the Technis Eye-Enhance, it's the DIB00, which is a preloaded, and the ICB00, which is non-preloaded. And we did use both of them. We didn't feel like in the study that the delivery mechanism was really all too significant in feeling like we needed to exclude one or the other. So the two big aims from this study, the first one is that we wanted to do our own U.S. cohort comparative study. There have been some similar studies done, which is our second aim, but none have been done in the U.S. And so we wanted to do a U.S. cohort study and also include some outcomes that some of the other studies didn't do. And the other part of the study is to do a structured literature review. Like I said, some of these similar studies on the Technis Eye-Enhance have been done in Europe and Asia. And so we did do a pretty comprehensive review of all of the literature that's currently out there. We analyzed what they had, we compared it to what we had, and then we were able to make some conclusions based off of the similarities and the differences. So our methods, this is pretty dense, so I'm not going to go through all of it, but just a couple of important things that I want to go through. So our cohort, we had 216 total eyes. We had 52 patients into the Eye-Enhance arm and then 56 in the standard monofocal arm. So it was pretty roughly balanced. The outcomes that we wanted to measure, so this is monocular and binocular uncorrected distance, near and corrected distance visual acuity. We did also take the means in logMAR, which is essentially a conversion of your Snellen visual acuity bins into something that's a little bit more that's a little easier to throw into, statistical analysis and math. And there's a pretty interesting conversion that we were able to follow from some other literature in doing that. And so we were able to get some means for those visual acuities. And then we also did take a quick look at manifest refraction. That didn't turn out to be too significant between the two lenses. And then one of the other important findings that we wanted to see was how patient-reported symptoms, dysphotopsia, dry eye, how those compared between the Technis Eyhance and just a standard monofocal lens. So distance vision, this is kind of what this was our baseline. This is what a lot of lenses are compared against, and so we didn't see any significant difference between the Technis Eyhance and the Technis standard monofocal lenses, which is a good thing, right? Because like I was saying earlier, when Johnson & Johnson marketed the Technis Eyhance lens, they said, hey, we are going to preserve the distance vision that you're able to get with a standard monofocal lens, and we're adding a little bit more to it. So you'll see on the graph that there were no statistically significant differences between the Technis Eyhance and the standard monofocal lens. And so that's essentially to say that distance vision is preserved in the Technis Eyhance lens, which is great. That's exactly what Johnson & Johnson wanted to do. And then jumping to kind of the big finding, this was something that we weren't expecting because, like I said, Johnson & Johnson, they were promising patients better intermediate vision, but they didn't really mention anything about near vision. And from this study, we actually ended up finding that the Technis Eyhance significantly improves binocular near vision in a clinically meaningful way. So you'll notice on our graph that at 2020, there wasn't a big difference between visual acuity, 2020 vision between the two lenses, and that kind of does play back to the fact that that the extended depth of focus design, it doesn't really give you a super crisp vision at the different distances. But there was a clinically significant, statistically significant difference between the Eyhance and standard monofocal lens at 2025 and 2032. So what that's telling us is, in terms of binocular uncorrected near visual acuity, there was a statistically significant difference. And so on top of the intermediate visual acuity that Johnson & Johnson is promising its patients, it actually does provide improved near vision as well. One thing that, as we were going through literature, we did find to be a little bit different is we didn't see any, in our study, we didn't see any difference between monocular uncorrected near visual acuity, but a lot of other studies did. One of the limitations of this study is our follow-up was only 1 month. We weren't able to work out much further than that just because of the design of this study, which I'll get into here in just a second. But not being able to look at the monocular uncorrected near visual acuity and then comparing that to what other studies have found, we didn't see any significant difference in the monocular near vision, but other studies did. We believe that in our study it has something to do with some mechanisms surrounding neuroadaptation that both eyes weren't able to fully individually see well at near vision compared to being able to work together. But our hypothesis, and something that we're starting to work on a little bit more in this lab, is seeing that if we are seeing a difference at longer follow-up appointments, and that's something that we're working on right now. But like I said, I mean, the big thing here is this was an unexpected finding, that this lens improves near vision. So if these lenses, the extended depth of focus, this Technis Eyhance lens, if its whole job is to improve vision at multiple distances, what separates it from a multifocal lens? From this graph, you can see that in this study we also compared the Technis Eyhance, right, this extended depth of focus type of lens, to our standard monofocal lens in terms of dysphotopsia following cataract surgery and implantation of both IOLs. You'll notice on our graph that there is absolutely no difference between patients experiencing glare or halos, or having night vision difficulties. These are the dysphotopsia, the photic phenomena that patients tend to complain about with multifocal lenses. So the fact that iHance was able to reduce the risk of experiencing these types of photic phenomena makes it a pretty desirable product for patients who want vision at multiple distances, but don't want to have to deal with the high risk of dysphotopsia that tends to come with multifocal lenses. And then jumping just quickly into the second aim, I have this massive graph on here. I'm not expecting anybody to see it, but these are the studies that we went through and the metrics that we wanted to compare across the 13 studies that we found in Europe and Asia who have been able to do similar studies. You can see that there's a lot of gaps in all of them, and so just being able to throw an extra U.S. cohort study in there helps fill in some of those gaps and helps paint the picture a little bit better. Just to provide a little bit more comprehensive literature out there about the Technis iHance IOL. So a couple of limitations. This study was done retrospectively, and the retrospective nature of a research study does create a couple of problems. We weren't able to randomize the types of patients that were receiving each type of lens, which can create some confounding variability. And then we also, just due to the clinic's charting, we weren't able to look at uncorrected intermediate visual acuity, which was kind of the big thing that their marketing, Johnson & Johnson's marketing team was trying to hit home. But like I said, we were able to fill in a lot of our conclusions about intermediate vision from our literature review from other studies that have been done. There are some future directions, some things that we are wanting to work up, that we're wanting to work on. We do want to move towards prospective randomized trials with at least 6 to 12 months of follow-up. Like I said, we're a little bit limited with just the 1 month follow-up. That created a little bit of data that we didn't necessarily want and didn't really match other literature. And so being able to do a randomized trial that looks out a little bit further would be helpful. We want to look at contrast sensitivity, defocus curves, reading speed, patient's quality of life with this lens, spectacle independence surveys. We took a very short look at corrected distance visual acuity, but we do want to dive in a little bit more to that. And then also direct head-to-head comparisons against some of the newer extended depth of focus lenses that are out there and some of the newer enhanced monofocal lenses that are out there that are similar to iHance. And then also diversify the populations and the cohorts that we're looking at. Yeah. So a couple of big take-home messages, 3 big ones that are kind of the big conclusions that we can walk away with. The first one is the Technis iHance lens does produce significant near vision gain. It preserves the distance vision that patients get with a standard monofocal lens, but it gives a little bit of extra intermediate vision. And from this study, like I said, some good binocular near vision. And from other studies that have been done, they support the idea that monocular near vision improves as well. And there is no dysphotopsia, or there's limited risk with dysphotopsia with the Technis iHance lens. It makes it a great option. Jumping into the third bullet point here, it's a great middle option for patients who they want the benefits of a multifocal lens where they want to be able to see at multiple distances, but they don't want the high risk that comes with multifocal lenses in terms of dysphotopsia. And like I've mentioned a couple of times, this really does come down to patient preference, because some patients are okay with settling with 20/25, 20/32 vision instead of 20/20 at all the distances. And so patients who have that preference and are okay with not quite the most clean clean vision at all of the different distances, this is a great option for those types of patients because it also limits the risk of experiencing those photic phenomena that you get with multifocal lenses. I'll take any questions right now. Just a quick thank you to Hoops Vision. This is where we did the study with Mahid Moshafar. He was our PI. He's he's a very smart man. I learned a lot from him. But yeah, we'll jump into some Q&A.
Any questions?
For your target goal, did you use first plus or first minus? Were you shooting on myopic side for your distance goal, or were you using the first plus?
So our distance goal, we're targeting emmetropia. I'm not really sure what, first minus or first plus, like what we were doing there, but we were targeting emmetropia instead of, what's the word? That's a good question. But we were targeting emmetropia. I'm not sure exactly the first minus or first plus.
Maybe you could.
So, I mean, I've gone back and forth with the iHands because if I'm trying to get great distance, I mean, you have those people like, don't mess up my distance, whatever you do. And I'm like, well, I can fudge this a little bit, and I go first plus, and I'll get a little bit of a stretch to make sure that it's great for distance. And then I've talked to the Johnson & Johnson rep, who sometimes suggests go just a little bit on the minus side to shoot for the first minus target refraction. That's my point of view.
Okay.
Stretching, Eunice, or a question? Stretching, okay. I missed it, and I apologize, but did you get any sponsorship by Johnson & Johnson, or is this?
This was
Okay, that's why
totally
you didn't
independent.
mention it, because there was none, so you should,
Yep.
that's something you should probably mention then, okay. Good. Any other questions? No, they got to record it. Yes, sorry about that, so you have to talk in the mic.
So I use the iHands a little bit in my practice. So I do the dominant eye plano, and then I do the non-dom about like a minus 0.5, and I tend to get a little more near vision with that. For your study, we're looking at both eyes for plano or emmetropia. Have you, or is there any indication or plans to do like a mini mono in the future, or?
We don't have any plans. That's not like our highest priority that we're wanting to move forward. But there are some studies out there that have done what you're asking about. I have some references I can run you through, but that has been done. There's actually a lot less. There's a lot less that we're targeting emmetropia.
Is anyone else doing a little mini mono? Yeah, I feel like patients do pretty well with that. I use the Aspire lens a fair amount too. I feel like that works good to give you a little depth of focus as well.
Any other comments? Oh, good, lots of good comments.
Yeah, I agree with the enhanced monovision or mini monovision, whatever you want to call it. But you have to be very careful on which lens you're using and how much you go minus. The Invista Aspire, you go more than minus 75, you're going to get some dysphotopsias and very unhappy patients on the Invista Aspire. The Rayner EMV1, my experience is you go up to minus 1.25. iHands, you can also go up to minus 1.25, give them true monovision. If you want to give them that little mini monovision, aim for minus 0.5. I always do the dominant eye first plus to first minus. Whatever is closer to plus 0.1 to minus 0.1 is my goal for my aiming for my dominant eye. Non-dominant eye is usually between minus 50 to minus 1, depending on what kind of ranges of vision they want, how much they want. The biggest dilemma on this, though, is that, financially, this is a lot of chair time. What do you charge for this? And these lenses are not premium IOLs or advanced technology lenses that you can charge for. So those are significant dilemmas that you gotta need to marry it with a lens X laser or an LRI to justify the time is spent on these type of things, is my comment.
I've been using the iHands for pretty much since it came out, and for the dominant eye, typically going right around plano, plus 0.1, close to that for the first eye. Second eye, I'll go minus 0.25, no more than minus 0.5. As far as monovision goes, Sertaz's his comment is very valid. If somebody, what I tell these people with the monovision is you're going to lose your depth perception. We have lenses that will allow you to have depth perception, i.e. the multifocals that will give you the full range of vision and push those people into that direction. If they want to be totally spectacle free, that's still going to be their best bet with one of the excellent multifocal lenses that are out here. But to Austin's question, the second eye going, minus a quarter, minus a half. It's surprising how much near vision they'll get. They're still going to need cheaters for fine print, but they'll be able to see their texts on their phone, read a menu in a restaurant, and all those sorts of things just with that minus a half.
Great discussion. Any other comments from anybody?
Great talk. I pretty much agree with what everybody said. I think the more I put these in, actually the less mono I think they really need. I think a minus a half in the non-dominant eye is plenty in most cases with this lens. My other comment is, did you have a washout for post-refractive patients? Or was that in the criteria? Did they wash out post-refractive in these?
Let's see.
If you don't know, it's okay. This is a great talk. You did a great job.
I'm not 100% sure. I know we looked at it. I just don't have the answer off the top of my head. But I can review the.
No,
the
it's
paper and
I put Eyhance in post-refractive patients. I've been criticized for that at times because there's somehow they've created the lens with using the increased sort of higher aberrations on the front part of the lens that could possibly induce more aberrations in post-refractive. So that'd just be one thing to consider. It's probably a washout in the study, but I don't know if other people have experience using Eyhance in post-refractive patients or if they're comfortable doing that or not. It's just a question that I had.
So just quickly, I just looked at my notes. That was one of our exclusion criteria, so that wasn't included in the study.
Well, thank you all for showing up. Everybody did a great job. And we have the other student and resident presentations 6 to 7 on Friday and Saturday also. So hopefully all of you will come and support the other students that are presenting at that time. And thank you all. And we're actually finishing a little bit early, which is wonderful.